احنا برضو في نفس الدكتورة سيشن، والموضوع مهم جدا جدا جدا. تفيد or not تفيد، تكملة للسابق ويمكن أحد أهم المحاضرات.
Alright, okay. Alright, so I'm on 13 slides, which is very small because I know everybody wants to go to pray, so I'm going to try to be very brief. Although the topic is very controversial and the topic is very important, because I'm sure كلنا كل يوم بنتسأل, should we pee, should we stop, what should we give, what are the ethical background behind that. I just want to say in America في حاجة عندنا اسمها ethics committee, which is different than the ethics committee that you have here, and hopefully in one day in Egypt it will happen. We have two different types of committee. You have the standard IRB committee when you want to do research, any kind of research, you get IRB approval. But we have what we call the ethics committee to answer these kind of difficult questions. Should I stop feeding? Should I withhold care? Should I continue chemotherapy? Should I start chemotherapy? It's a group of people who studied the science of bioethics. We actually have also a lawyer who's also presenting the law to make sure patients are protected and what the law says. And then we come to a clinical consensus. What should we do? So I'm going to spend the next few minutes talking about ethics surrounding the decisions to feed or not to feed, especially in the end-of-life care. So, the natural dying process, we all know that the human body needs food or water to survive, and as patients approach death, it's natural that their oral intake gradually decreases before completely it stops. And this might sound shocking for the family because they don't really get that. They don't understand what does it mean that my mom is not going to eat, or what does it mean that she's not asking for food or whatnot. Usually, and on average, it takes about 1 to 3 weeks of a person without any food or water to die. And we're talking about patients with advanced illnesses. Someone has metastatic cancer, you stop food, you stop water, they're not going to die right away. And very important to explain that to the family. Because family has this guilt, I'm starving my mom, starving my dad, how come you don't want to give them anything? And we face these decisions all the time. These clinical scenarios where family are really struggling. You know, they want to wake them up, aspirate, you get aspiration pneumonia, the patient's already having terminal secretions, and it's very controversial. So you have to explain to the family, just because we stopped food, you're not going to die right now. They have all these things stored in until they officially, end their life. So elderly and terminally ill patients may deliberately limit their food, especially in patients who have advanced cancers, or especially patients who are elderly and they have multiple conditions. If they remain adamant, their actions must be accepted, and other might refuse to eat with no clear reason. This is where we say a window of opportunity to have discussions with the family and the patients and ask. And I'm not sure how it works here in Egypt, if we actually talk to the patients a lot or we just talking to the family the majority of the time. But this is where we talk about the concept of autonomy. At the end of the day, you have to decide what's good for you. And I understand sometimes we don't want to tell our loved one they are sick. My own mother died of cancer without even knowing that she had cancer. I mean, she's smart enough to know that she had it, but we never walked around saying, Mama, you have cancer. We never said the word cancer. It was the elephant in the room. Her heart fell off, she had cancer, she was getting chemo, but we never actually sat down and talked about what does it mean, right? And this is something that it's just in our culture is not embedded. So even if you don't do it with the patient, it's always important to do it with the family, but set realistic goals. Talk about what is actually happening right now. Explain the reality and where we are in the process of dying or chemotherapy, radiations, or palliative or hospice or whatnot. And even in Alzheimer patients and demented patients, even in America, we face that question all the time. So the patient is 68 years old, they were newly diagnosed with dementia. Okay, am I just going to let them die because you can't eat because of their dementia? And the answer is, okay, should we put a feeding tube? What are the questions? Should we put a feeding tube or should we not? These are the type of questions that we get. Just keep in mind that even feeding tube patients may need to be physically restrained or sedated, resulting in immobility and risk of partial ulcers or whatnot. So the clinical consensus is if someone has dementia and at the same time they're doing functional well, they only have dementia, they don't have multiple comorbidities, they're in good function status, yes, you should continue to feed them. You shouldn't just say, okay, khalas, you're 70 years old, you have dementia, you have ALS, just forget about it. No, as long as you have good prognosis and as long as you have good outcomes, why not? So, very quickly, and we just heard a little bit from Catherine about that. Artificial hydration, we call artificial because it's something extra. It's like a process. It's something like complementing. So with the development of artificial nutrition hydration, patients are able to continue living longer despite no oral intake. Even though they cannot literally chew the food, there are multiple ways you can still giving them nutritional support. So for example, giving like intravenous, like TPNs or parental nutrition of some sort. Even doing like hypodermolysis, like, through the skin. Even from nutrition, if you have someone who are not going to eat for the next week or 4 weeks, you may put a feeding tube. Like let's say you have a patient who has head and neck cancer. You're going to give chemo, you're going to give radiation. It's expected that this patient is not going to eat for the next 4 weeks or longer. Yes, this patient might be a good candidate for an NG tube giving through the nose or down the throat or whatnot. And then even if someone who's going to need nutritional support and they're going to live longer than 4 weeks, someone who has dementia, ALS or whatnot, yes, you should, as long as they have good functional status, give them a PEG feeding tube through the stomach. So, who benefits from artificial nutritional support? As I mentioned, definitely ALS patients, patients who have Parkinson's, patients who have dementia, patients who have reversible, and that's the trick, reversible. We're not talking about irreversible cancers. We're not talking about advanced cancer. We're talking about early stage. We talk about someone in stage 1 or 2 or 3. Once the cancer spread, and like, Catherine and Sammy said the same thing, it's irreversible cachexia. Even if you put a feeding tube, it's not going to do anything. Even if you give them TPN, it's not going to do anything. At this point, you focus more, like you mentioned, the psychosocial, the psychological comfort food. Chew it and spit it, not necessarily swallow it and get the benefit from it. Even for patients who have cancer, and especially for people who have gastric cancer, sometimes they get obstruction. They have gastric outlet obstructions. You can do artificial nutrition support for them. So again, anytime you have someone who has a duration, need nutrition support for more than 4 weeks, and have good likelihood of recovery. That's also another trick, that that they will recover from whatever they're going right now. So it's not an irreversible condition. Also, a hand feeding, which is known as an assisted oral feeding. It's an alternative to tube feeding. Generally used in patients who have dementia, have fewer risk because you're not putting a line, you're not puncturing the skin, you're not putting a tube, and it's actually having like someone feed them, their family, but in like small quantities. So, what are the pros and cons to artificial nutrition and hydrations? The pros in that you prevent dehydration. The fluids can improve the renal clearance of those who are experiencing side effects from certain drugs, like chemo or other medications. But the cons is that they could get fluid overload. If they have an IV line, you get a side of an infection, discomfort. The PEG feeding, a lot of people complain of discomfort in the stomach, abdominal pain, and whatnot. So just thinking about, and this is when we say it's an ethical dilemma, because it's never a one size fits all also. It depends on the patient, right? Sometimes you say, no, the patient is very young. I'm going to do whatever means it can because I want them to continue eating. I want them to continue gaining weight because I want them to continue chemotherapy. I want them to, there's chances of remission is very high for them to get cured. So of course I would push for that. I'll push for artificial nutrition support. But if someone, we get that. We get families sometimes 105 years old. They want to put a pig feeding tube in their mom who has dementia and has like comorbidities and whatnot. It makes absolutely no sense, because looking at the overall prognosis, it's not even a good prognosis to push for that. So fluid overload, also keep in mind that, there are fluid overload. This is when we talk about the con, there are other issues. You can have additional stress on the organs, contribute to edema, congestive heart failure, can contribute to pneumonia, contribute to extra fluid in the GI tract, like bloating, aspiration, and diarrhea and whatnot. So the argument for allowing withdrawal. So when is it okay? When is it okay to actually stop? When is it okay to say, okay, I'm not going to push for aggressive, artificial nutritional support. So definitely if patients are in a vegetative state, there's no point you should do this anymore. You can totally feel okay discontinuing, whatever artificial nutrition support they're getting, because you cannot associate that it will not cause any pain. You can, even if you continue, supplementation is costly. So we talk about supplement, like the Ensure or the food, like you mentioned, or the hot dog. All these things are expensive, but patients can't afford it. and the overall prognosis is terminal, there's nothing you can do. Exactly. If it's terminal, you should feel, this is where the ethics comes in, it's okay, it's acceptable to discontinue treatment, but you have to talk to the family about that. Very important to talk about this. Within the Christian ethics, they agree that artificial nutrition support is a medical intervention. It's not part of an ordinary routine of care. It's something extra. So this is where also differ. Like for example, in America, you know, people come from, we have different sectors. We have Muslims, we have Jewish, we have Christians. Jewish people are the most difficult patients when it comes to end-of-life care. They are very difficult because they believe in like natural death. So they will keep their loved ones on machine, they will keep hydrations, they will keep TPN, and sometimes it requires a lot of discussions to bring in their like religious figure like the rabbi and the family to try to explain the reality that we're doing more harm and creating more harm than benefit, right? It's all about harm and benefit. This is how you make the decision. Also, we explain to the family that part of the dying is that you stop eating and drinking, right? It's not like you just stop. So we want to allow the natural process to come to place and we want people to die naturally. And feeding also explain, very important to explain to the family, it's not just about putting a feeding tube. Feeding tube comes with its own cost. Discomfort, abdominal pain, clogging of the tube, things get stuck in the tube all the time, causes even more discomfort for the patients and whatnot. So explaining the reality of the situation. So arguing also for not allowing withdrawal. When shouldn't you do it? Or people, this is where the dilemma becomes. In many cultures, like for example in Egypt, and you said that, Sammy, food and water are symbols of care. So if you stop it, we get this all the time, even in the States, oh, you're letting my mom die, she's gonna starve. Believe it or not, even for our end-of-life care patients, just to make the family happy, although there's no clinical benefit whatsoever, sometimes we have normal saline running at 10 ml an hour. It means nothing. But when the family sees it hanging, they're getting something. Meanwhile, they're getting half a bottle of water a day. Is it going to do anything? Comfort the family, exactly. Do you think this is actually benefiting? Drinking like half a cup of water, benefiting the patient who's terminal and who's dying end of life? No. But it's for the it's exactly for the family to bring them take the ease, take the guilt feeling away from them. Exactly. It's talking to the family. Also dehydrations, and this is where we explain to the family that dehydration and starvations would be the cause. This is what they think. They will say, oh, this is why they are dying, because we didn't give them food, they didn't drink. No, we need to explain also, and this is where we talk about they are dying because unfortunately they have irreversible conditions. They have cancer that metastasizes, cancer that spread. So regardless of the food, it's a situation where you cannot reverse it, right? And similar also, this is where this whole ethical dilemma, I forgot to mention that in the beginning, came from actually families going to the court, suing physicians and asking, these physicians are not feeding my mom, they are assisting them to die. They are creating euthanasia, for example, or pro-suicide. That's exactly how it started. Families going to the mahakim, going to the court, saying, this doctor doesn't want to feed my mom. This doctor is causing my mom to be starved and whatnot. And when the court got involved and the lawyers and the bioethicists said, this is not true, right? Stopping feeding in someone who's terminal, or stopping like water or feeding altogether, you're not assisting suicide. You're not. This is a normal process of dying, but this is where the dilemma came into place. So what's the right thing to do? The right thing to do is to respect the patient's wishes. What do you want? What does the patient want? And I know that by itself in Egypt represents a dilemma. Because oftentimes it's the family who's deciding and not necessarily the patient, right? But I believe, and it's not because I live in the States, but I really believe that patients should have the right and should have the absolute right to decide for themselves what they want to do, right? Yes, even if we cannot deliver bad news to them, we have many ways that we can deliver information to them, but it's your right. I don't want, with all due respect to every physician, I don't want a physician deciding for me what to do. I want to be able to decide what to do for myself. It's the concept of autonomy. If patients has the right also to decline, we have a lot of patients who decline treatment. Believe it or not, even patients are Muslim, Christians, or whatever, you have the right to decline treatment or continue treatment. And if patients is unable to communicate, we have what we call in the States, and I don't know if it exists in Egypt, something called an advanced derivative, which is a legal document where actually patients, when you get ill or you get sick, you go and you write down what exactly do you want to be done in a case you're sick. And in a case you cannot communicate this information, we actually have what we call a healthcare proxy. A healthcare proxy is someone that you designate. And it doesn't, by the way, have to be your mom or your dad or your spouse or your partner, whatever. It could be anybody. As a matter of fact, my healthcare proxy in the States is my best friend, because I know my sisters will keep me on that machine forever. They will do whatever it takes to keep me alive. They will not necessarily do against my own wishes. So healthcare proxy is someone they have a conversation with, and it could be your best friend. You tell them, in a case I have advanced illnesses, in a case I have advanced cancer, in a case whatever, this is what I would like to be done for me. In case I cannot verbally communicate, I cannot get this information across. So also we have this, just as the last slide, we have this form, it's called the Medical Orders for Life-Sustaining Treatment. It's called the MOLST form, which is this pink sheet that we have. And it's basically any patient who have a life expectancy less than 1 year. So we talk about like hospice patients, end-of-life care patients. This document basically is filled out by a doctor after discussion with the patients and their family. We sit down and we talk about the prognosis. We talk about where are we right now in terms of treatment. We talk about should we continue more chemo, more radiations, more aggressive hydrations and whatnot. And one form is signed by the doctor and the patient. The other form is sent into the patient's medical record in case the patient goes from one hospital to another, to prevent rehaving the same conversations over and over and over and over. I know, I'm not sure how it works here. Maybe Sami, you can elaborate a little bit. If we have any kind of, in Egypt here, do we have anything like advanced derivatives, living well, healthcare proxy, and whatnot? We don't even have DNR. Okay, I'm going to be honest with you. By the way, I know عشان بس ما يبقاش في fantasy, all these things came to America only about 20 to 30 years ago. Bioethics as a concept was only invented in America in the 70s and the 80s. So don't think يعني America أحسن حاجة. So this is an opportunity to catch up for us here in Egypt, to start thinking about these things. What do patients want? Like when you see your cancer patient next time, think about asking them, what do you want, right? Rather than like looking at their family and having the conversation mainly with the family and whatnot. So don't think like, oh, عشان دي America. No, it's only like 20 years ago or only like 30 years ago. This stuff started to exist. This form is only 10 years ago, as a matter of fact. It didn't exist before 10 years ago. So there's definitely a window for opportunity, because at the end of the day, everyone wants to die with dignity. Everyone wants to die in comfort, and that's exactly the ultimate goal. And that's pretty much it. Thank you.